Welcome to the Deep Dive. Today, we're heading straight into the endoscopy suite. We're going to explore the really disciplined, life-saving pause known as the timeout.
Mm-hmm.
And just so you know, this entire deep dive, it's built on insights from some great expert educational resources. We're talking detailed learning materials and, importantly, Dr. Raju's YouTube video series.
That's right. These are resources specifically tailored for, well, for you listening, the dedicated nurses and technicians who are mastering this field.
Exactly. Our goal today isn't just to recite a checklist.
No, definitely not. We want to give you a more strategic understanding of why the timeout is, the anchor of procedural safety.
And we really want to spotlight the role of the endoscopy technician. We're calling them the quiet expert.
I like that term because their unseen choreography, that setup work, is what makes these complex procedures look, well, almost simple.
It really does. That phrase, unseen choreography, it's perfect. Think about it. When the endoscopist walks in, everything's just there. Positioned, powered up, primed.
Ready to go.
And that smoothness, that's entirely down to the technician. They've already checked the air, the water, suction, light, tested the insufflation, laid out every single tool needed.
Precisely. And that groundwork, that preparation, is what allows the entire team to hit that safety pause button with real confidence.
Okay, so that groundwork is obviously critical. Let's maybe start with the big question. Why is this mandatory halt even necessary?
Good question. Let's unpack that.
I mean, you've got a room full of highly skilled people, right? A seasoned endoscopist, an expert anesthesia provider, experienced nurses. Why the need for this structured minute-long pause? Doesn't their skill level kind of handle most potential errors?
You'd think so.
Mm-hmm.
But it's actually because they're highly skilled that the pause is so effective.
Yeah.
Endoscopy, using that thin, flexible tube, the endoscope, to look
Or
inside.
an EGD or colonoscopy.
Exactly.
Right.
To look inside and maybe treat issues.
Yeah.
It's inherently fast-paced, high-stakes. So the pause isn't about questioning their skill. It's more about acknowledging, well, human factors. You've got this mix of people, potent medications, complex machines.
A volatile mix, as you said.
Right. And the timeout is the way the team synchronizes.
Yeah.
It's their chance to catch those tiny errors, maybe transposing a birth date, misunderstanding a medication instruction before they snowball into something serious.
Ah, so it's like the medical version of a pilot's pre-flight checklist.
Spot on. The pilot knows how to fly the plane, no question.
Right.
But that checklist, that's the shared failsafe. It guards against that momentary lapse, that small oversight.
Makes sense. And the timing you mentioned, it's non-negotiable. When exactly does it happen?
Two key moments.
Mm-hmm.
First, before any sedative medication is given. This is crucial. So the patient, if they're able, can participate and confirm their details.
Okay, active patient involvement.
Absolutely. And second, it happens before the endoscope actually enters the body.
Yeah.
You want to fix any gaps when it's still easy, still theoretical,
Right, before you're committed. And who has to be involved? Who stops what they're doing?
Everyone directly involved in that procedure or the patient's immediate care. So that's the endoscopist, the anesthesia professional, the nurse, and the technician.
The core team.
The core team. And like we said, the patient too, whenever possible. And once it's done, once everything's confirmed, it gets documented, a quick note in the chart locks it in, shared alignment confirmed.
Okay, so we've got the ground rules, the why and the who. Now, let's break down the actual choreography. How does it happen? This brings us to the mechanics, the 3 core verifications.
Yes, this is the structured part, designed to just eliminate any confusion.
Let's start with verification 1, identity.
This is non-negotiable. The patient has to state out loud at least 2 identifiers. Usually it's their full name and their date of birth.
And often the MRN too, right?
Often, yes, the medical record number, because that's unique to their entire hospital record. And the key is the entire team has to match what the patient says to the wristband and the electronic chart.
Multiple sources confirming the same data.
Exactly. That's how you prevent those awful identity mix-ups.
Oh, okay, makes sense. Verification 2, the procedure. How specific do we need to be here?
Very specific. The team needs to clearly and explicitly name the planned procedure. Not just scope, but the full name, like esophagogastroduodenoscopy or colonoscopy with possible cold snare polypectomy.
And the crucial part.
The patient has to verbally agree. They have to say, yes, that's what I understand we're doing. If the patient looks confused or says something different.
Like, I thought it was just a checkup.
Precisely. If there's any mismatch, everything stops immediately until it's resolved.
Got it. And verification 3, site.
This one's only confirmed when it's relevant. If there's laterality involved, a specific side, like left versus right or a specific location, Needs marking, like for some complex ERCPs maybe.
So if there's a mark on the patient?
You verify it.
Hmm?
If site marking isn't relevant for the specific procedure, like a standard EGD, the team just states that clearly. Site marking, not applicable.
Okay, the big three. Identity, procedure, site. But you mentioned the sources also emphasize something called a safety cross-check huddle. This sounds like it goes deeper.
It does. This moves beyond the basic logistics into really active risk mitigation.
Hmm.
This is where you confirm information that could cause serious problems if missed.
What kind of deep dive info are we talking about here?
Okay, first up, allergies. You
Yeah.
absolutely have to review documented allergies. And if something's relevant, like a penicillin allergy, you confirm the plan. Maybe it's using a different antibiotic for prophylaxis.
Makes sense. What else?
Second, current medications. And this is a really big one for endoscopy. Blood thinners, anticoagulants, even certain supplements people take.
You touched on this earlier. It's not just knowing they take the med, but confirming its status, right? Like whether it was held. Can you expand on that? How does that turn risk into a plan?
Absolutely. Let's take that example, Ms. Lopez on Coumadin, a blood thinner. If the team just knows she takes it, okay, that's information.
Yeah.
But if the plan involves a biopsy or taking out a polyp, the bleeding risk is suddenly very high.
Okay, yeah.
So during the timeout, confirming that she actually stopped the Coumadin 48 hours ago, just like she was told, that shifts everything. The team isn't just bracing for a potential hemorrhage. They're proceeding with an acceptable, managed level of risk.
And if she forgot, if she says, oh, I took it this morning.
Then bam, procedure is stopped. Or at least significantly altered, maybe delayed. You've just prevented a major, potentially life-threatening bleed right there.
Wow. Okay. What other crucial checks happen in this huddle?
Implants are key. You check for pacemakers, defibrillators, any surgical clips left behind from previous surgeries.
Right.
These can affect choices about using electrosurgery, for instance.
Right, equipment choices.
Exactly.
Yeah.
You also confirm both consents are there, the one for the endoscopy itself and the one for anesthesia. Signed, present, correct.
Double-checking the paperwork.
You have to. And finally, the team visually confirms the correct scope model is ready, and all the necessary accessories, biopsy forceps, snares, clips, whatever might be needed, are actually there and working.
Let's use that scenario from the materials, Ms. Lopez, to see how this works in practice. Say she's in the room, scheduled for a colonoscopy. How does the timeout play out, especially if there's a hiccup?
Okay, so the team starts the timeout. Nurse asks Mrs. Lopez for her name and date of birth. She states them clearly.
Team checks wristband, chart, MRN.
Correct. Then the endoscopist states the procedure. Okay, Mrs. Lopez, we're planning a colonoscopy with possible removal of 2 anticipated polyps.
And in the scenario, Mrs. Lopez looks a bit unsure.
Yeah, she frowns a little and says, wait, 2 polyps? I thought this was just a general check.
Ah, there's the mismatch. What happens now?
Everything stops. The nurse quickly checks the pre-procedure notes, the consent form discussion. The endoscopist steps in, clarifies gently, reminds her about the findings from her previous tests, and confirms the plan for removal was discussed beforehand.
And Mrs. Lopez remembers.
In this scenario, yes. She says, oh, right, yes, I remember now. The team then documents that brief confusion, the clarification, and the final agreement. Then they continue the checklist.
Confirming her penicillin allergy, the plan for safe antibiotics.
Right. Confirming she did stop her blood thinner 48 hours prior. Confirming the scope and all the tools are ready to go.
That little hiccup really shows the value, doesn't it? It forces clarity.
Exactly. And notice the required tone throughout all of this. It has to be calm, clear, unhurried. You don't rush safety.
Right. If anything seems off, even slightly, the team just stops and fixes it. That calm reflects, well, a confidence in their disciplined preparation.
Absolutely. The true professionalism shines through not just in the technical skill, but in that willingness to pause, to be deliberate.
Which brings us perfectly to the third part of our deep dive, the technician's edge. This is where that quiet expert's preparation really transforms safety and efficiency. We're moving a bit beyond the timeout itself now, into the physical setup.
Yes, the setup that keeps the whole room running smoothly, in rhythm.
Let's look at 4 sort of strategic elements highlighted in the source material. First one, ergonomics is patient safety too. This sounds interesting.
Oh, it's huge for procedural rhythm and quality. The technician is largely responsible for optimizing the endoscopist's physical environment.
How so? What are the specifics?
Okay, key things. Placing the main video monitor directly in front of the operator, not off to the side, and ensuring the top edge of that monitor is at, or maybe just slightly below, the operator's eye level.
So they're looking straight ahead, not craning their neck up or down.
Exactly. Neutral neck position. And the bed height, that's crucial too.
How high should it be?
It's about geometry, really. The bed needs to be raised so that when the endoscopist is holding the scope controls, their elbows are bent at roughly 90 degrees.
Okay, like a comfortable working height.
Right. It gives them the best mechanical advantage and minimizes physical strain on their shoulders and back.
But why does focusing on the endoscopist's neck and shoulders matter so much for the patient?
Because operator fatigue compromises the quality of the procedure. If the endoscopist is fighting an awkward setup, constantly looking up, straining their neck, reaching uncomfortably long-term injuries are one risk, sure,
Okay.
but more immediately. That physical strain can introduce tiny hand tremors. It reduces focus and stamina, especially by the third or fourth procedure of a busy day.
Ah, I see.
Yeah.
So a comfortable, relaxed operator means better focus, more precision.
Better precision, potentially shorter procedure times, and just more consistent, high-quality work for every single patient. It's directly linked.
Okay, that makes a lot of sense. Strategic element number 2, data integrity starts early.
This is where a really sharp technician shines. It's about getting the data right from the very beginning. Before the timeout even starts, the tech is entering key patient identifiers, the names of the team members, and the specific scope details, model number, serial number, into the computer system or the procedural record.
Ah, so they're preloading the information.
Exactly. So when the team does the verbal pause, the screen data is already there, ready for that instant cross-check.
So during the actual timeout, they're just confirming. Person in the bed matches the wristband, matches the screen.
Precisely. This simple step helps prevent those awful ROM chart errors, attaching procedure notes or images to the wrong patient's electronic file. That's a logistical nightmare and a huge compliance issue to untangle later.
The technician is like the first line of defense for data hygiene.
That's a great way to put it, yes.
Okay, third insight. Positioning is geometry, not just comfort.
Right. Specifically for an upper endoscopy and EGD, the standard positioning is crucial. The patient needs to be in the left lateral position.
On their left side.
On their left side, yes. And importantly, with their head and neck kept aligned straight with their spine, not flexed down or extended way back.
And this isn't just for comfort. You said geometry.
It's primarily mechanical, actually. That alignment, left lateral, straight neck, creates the straightest possible path down the esophagus for the scope.
Ah, so it makes insertion easier, smoother.
Much smoother. Less friction, less potential for minor trauma or discomfort during insertion. Plus, there's a secondary safety benefit. It helps saliva and any secretions pool away from the airway, reducing aspiration risk.
Clever. Okay, and the final strategic element, secret 4, anticipation beats reaction. This sounds like the mark of a truly experienced tech.
It really is. This is that almost intuitive skill of watching two things simultaneously. The endoscopist's hands and the image on the video screen.
So they're reading the situation.
Exactly. A top-tier technician doesn't wait for someone to yell, "biopsy forceps," when they see the endoscopist maneuvering towards a suspicious-looking lesion or a polyp.
They're already getting the tool ready.
They have the likely tool, maybe it's forceps, maybe a snare, maybe a clip applicator already open, primed, and ready to be handed off seamlessly into the sterile field, often before they're even asked.
What does that anticipation buy the room? What's the impact?
It buys crucial seconds, and it reduces the mental load on the endoscopist. If a needed tool isn't ready, the operator has to hold the scope steady, sometimes in a physically awkward position, awaiting. That adds time, adds fatigue.
Right.
If technician, through sheer anticipation, can shave off even 20 or 30 seconds multiple times during a procedure, and you multiply that across a whole day's caseload.
That adds up significantly.
Hugely. It translates to less stress in the room, tighter adherence to schedules, and ultimately a calmer, safer environment for every patient that comes through. It's the definition of making complex work look, well, almost effortless.
Okay, so let's try to synthesize the key takeaways from this deep dive for everyone listening. We've covered the absolute mandatory requirements of the timeout verifying identity, procedure, and site.
The big three.
And we've really dug into how the technician's role through things like smart ergonomic setup, meticulous early data entry, understanding the geometry of positioning, and that crucial skill of anticipation. How all that transforms the safety and efficiency of the whole suite.
I think the bigger picture here, the underlying mindset, is really about discipline. The timeout models this habit. Pause. Confirm. Then proceed with clarity.
It's not accidental.
Not at all. Great procedures, the ones that look smooth and easy, They only look that way because every single detail, from checking the scope serial number before you start to the angle of that monitor, is handled with rigorous discipline,
It's fascinating, isn't it? The actual timeout might last less than 60 seconds.
often just 30 or 40 seconds.
Yet its impact, its success, protects a patient for a lifetime. So maybe a final thought for you listening, especially if you work on these front lines. How can you take this checklist habit, this deliberate pause, and translate it?
Yeah. Think about other high-stakes moments in your professional life, maybe even outside the clinical setting. That intentional discipline, stopping to make sure everyone's aligned, the data is right, the goal is clear, you can export that anywhere.
Like preparing a big presentation or even a complex team project.
Absolutely. Take that formal minute. Ask, who is ultimately responsible here? What are the absolute must-haves for success? Why are we doing it this specific way? Taking that moment to turn potential confusion or risk into a controlled, shared plan, that might be the most powerful safeguard you can put in place, no matter the task.